Hi, everybody. Welcome to this month's live Q&A at Winona. I'm Angela, your host, and I am here with two of Winona's favorites, Dr. Green, Dr. Cat. We are going to start taking your questions very shortly, so if you're here with us, please start putting your questions in the chat, and I'm going to let Dr. Cat and or Dr. Green, I don't know who wants to go first, introduce themselves, and then we'll get started.
Who wants to go first? Okay. All right. Well, I'm Dr. Kat Brown, and I am one of the Winona physicians in the state of Pennsylvania and Florida and Michigan and now Hawaii. Recently took on the position of medical director, so I'm helping to curate some content on our website for educational pages for our patients. And I have been an OB/GYN now for 20 years. Did my residency in the Army, and am I frozen? I just got a little failure thing here. Let's see.
No, I think it was the restreaming error.
Oh, okay, okay. I wasn't sure if that was me personally or if that was the
No, I got worried too. I came on mine, so it's like you. It's not just me.
Okay.
No, it's okay. You're good. Everybody's good. Keep going.
Anyway, so I was in the Army. They paid for medical school for me and for college. And so I spent a lot of time moving around the country, taking care of female soldiers and also wives of male soldiers, and have dedicated my career to women's health. And now I'm really putting my effort toward helping menopausal women because I am one of them. So I have a vested interest in making women's health care better for us in midlife. So that's me in a nutshell. I'll pass it to Dr. Green. And my house is a little chaotic because we've just adopted a bunch of animals. So you might see little critters running behind me.
So hi, my name is Mike Green. I am also an OB/GYN. I happen to be the Chief Medical Officer of Winona. So yeah, we get this giant pop-up with this like big warning. So when we pause and have like the deer in headlights look, that's what's going on. Sorry about that.
Sorry,
so anyway, and I'm been with Winona from the beginning. I helped design all the sort of medical part of our company. And I've been doing women's health my whole career. I finished residency in '99, so wow, that's 25 years. I guess I've been doing this now, and it's just been a joy. So this is pretty much what I do. I still see patients in the clinic a couple half days a month, mostly to be part of my community, but I pretty much devoted myself to this project, and it's really exciting and a lot of fun to take care of you guys. So let me just say, please put your questions in the comments. Otherwise, well, it may be more fun because we can just watch Dr. Kat's animals and stuff, but really we're here to answer your questions. So, so go ahead and start typing away. But actually, I think Dr. Kat has an article she wants to talk about a little bit while we're waiting for some questions to come in.
Yeah, so a lot of buzz you'll see online right now. A lot of our fellow other menopause educating physicians that are on social media are talking about this, but an article was released earlier this spring that basically, the title of the article is that randomized trials of estrogen alone and breast cancer incidence, a meta-analysis. And basically the conclusion, where they looked at all these different trials, the totality of their evidence showed a conclusion that estrogen alone use can significantly reduce breast cancer incidence, which is not really news to us because what we've known in the past from the Women's Health Initiative study and studies in the past is that the increased risk for breast cancer is really when you take combined estrogen and progesterone containing hormone replacement therapy. And so this article coming out, I think, is you know, it's nice because it's something we as menopause specialists knew, but it's nice to come out and have other people read this because there's still such a fulminant fear of HRT and a fear that a lot of people have out there of just prescribing estrogen at all. And the fact is that estrogen is so beneficial to a woman's body. And we've known that it's helpful in so many different arenas, and really women function optimally when their estrogen levels are good. And so this is something that just supports that, that if we stabilize a woman's estrogen levels, that it can reduce their risk. So I think it's worth talking about because you're going to see it in the media, and when you're scrolling, if you're in our target demographic and you have other menopausal educators on your feeds and your reels, when you're going through, you're going to see this and you're going to see them talking about it. So I thought it would be worthwhile to talk about here as well. So I don't know if you want to add to that, Dr. Green.
Yeah, I just kind of what we were chatting about before we started is that when the Women's Health Initiative study first came out with this, I didn't believe it. I'm like, and I'm looking, there's got to be a confounding variable. There's got to be some reason that it's like, well, that's not everything I've ever heard of. And so I was pretty skeptical. And then article after article started coming out showing the same thing. And it's like, wow, I guess this is real. That's pretty cool. And it's kind of mind blowing how backwards people have it, really. You know, people think, oh, progesterone's safe, estrogen is scary. And it's almost the opposite, really. It's progesterone that gives a lot of the risk, not the estrogen. I mean, estrogen can give some risk, but it's really the progesterone. Now, here's the kicker, though. If you still have your uterus, you still need the progesterone. So yes, it may slightly increase your risk of breast cancer, but taking estrogen alone, if you still have a uterus, is really very dangerous. So don't stop your progesterone. That's really important. But we do know that it's not the estrogen that really causes the problem. The estrogen's actually very safe and probably has some protective benefit to the breast, which again is kind of a surprise because it's opposite of what you hear all the time. But that's what the data shows.
Yeah. And I think it's interesting because I certainly have a lot of patients that come to us asking for just progesterone. And when I look at their symptom profile and I see them list, you know, hot flashes, night sweats, brain fog, insomnia, when I look at that list of symptoms, I tell them right off the bat, like, we could do progesterone only if you really want to, but you're really going to have limited relief of your symptoms. And I think it just comes from this fear. Everyone is so afraid of estrogen, and I don't know why, because it's such a good hormone for us. So I think that it's, you know, we have to change, you know, swing the pendulum the other way.
It's funny. That's the exact conversation I had with the last patient just before I signed on to the live stream with somebody that had requested progesterone only. And I'm like, what are you worried about with the estrogen? Because that's really where it's the estrogen that does the heavy lifting. That's what does most of the symptom benefits.
Yeah, absolutely.
We got some questions?
We do. Are you guys ready? I'm taking everyone, so get ready. I got a pen and a notepad because this is
old school.
1970s. Okay, first question. And it is from, I don't know if I'm going to say your name right, Casa. It says, hello, is it safe to use HRT beginning in your early 40s and continuing through menopause?
Yes, it's safe to start using HRT when your symptoms have become bothersome. And so a lot of people out there really, unfortunately, have it wrong where they think that you need to wait until a woman has gone through menopause before they initiate therapy. And actually, it's more beneficial to start as the symptoms start creeping in and as you start noticing these changes. So for many women, it happens in their 40s, early 40s, mid 40s. And then we can continue the HRT and as long as they need it. So, you know, the old rule of thumb was the lowest dose for the shortest duration that we need, but really it's about optimizing your quality of life and helping your symptoms so that you can be your best self. So however long that takes for most women, you know, it's something that we can discuss on a case-by-case basis.
Okay, we have a good question from Wardia. She asks, how do you customize to each individual? So
it starts off with the patient filling out our adaptive questionnaire and letting us know what form of medication that they're most interested in, you know, because there's several different ways of HRT. And so it's like trying on clothes. It's the way that I kind of describe it to patients. You know, every woman likes a different cut, a different feel, a different style. And so it's all about what form of medication you feel could fit into your lifestyle the best. Because if it's something that I like for me, but it's not something you could remember to do, it's not going to help you if you don't take it regularly. So that's the first part. And then we have an algorithm that Dr. Green developed that helps us to have a good our best guess for the first starting dose, no matter what form that we're going to start with, whether it be pills or cream or patches. And so that's really how we customize. And the other good thing is you're able to have an ongoing dialogue with our doctors so that, you know, we can fine tune your dose and customize it to you as you go through the treatment, you know, with the medication. So it's something that you're not locked in with the first choice that you make. We can adjust the dosage. We can always change forms until we find what fits best for you. So
let me add one last thing is we also have compounded medications. So when we have pills and patches, but when you're using a pill or a patch, there's really fixed doses and there's not that many choices in some cases. And so it's a lot harder to customize treatment when you're using these sort of commercially available treatments. We have our own compounding pharmacy. Our pharmacists compound the cream in our pharmacy. And so it gives us a lot more leeway about the dosing schedule, and we can really tailor things and fine tune them to get it just right for you. So that's one of the things that we have the ability to do that, you know, because we're so fortunate to have such excellent pharmacists and such a great compounding pharmacy, that we can do that for you. And that allows us to customize as well. So it's kind of another piece of the puzzle, so to speak.
Yep, that's true. Nobody else doing it, but Winona's doing it. So come to Winona.
And if you missed it last month, I assume that's it's up somewhere. We had our head pharmacist, Joshua Gerke, kind of go over really the science of compounding. I learned a lot.
I did too. It was great. It's on our YouTube channel. So if you go to Winona on YouTube, then you should be able to watch that from last month. I think that was a really good one. It's really good information about our compounding process.
Yep. I love that we have pharmacists who can speak to complicated processes like that. So yeah, definitely check out YouTube. It is there now live. And I will, while we're talking, I'll see if I can put a link in the chat for anybody who would like to take a peek at that. In the meantime, Casa has a question about HRT and hormonal acne. And I kind of personally am being nosy and want to know more about this next statement, which says, I mentioned to my dermatologist and she made me feel worried about both safety and acne. What did she tell you? I'm just curious. Guys, who wants to take this one?
Let me just start by saying that it's a mistake to get your HRT advice from a dermatologist, and it's a mistake to get your dermatologic advice from a gynecologist. Okay, so you know, we all have some broad idea, but we also kind of should be, to some extent, staying in our lane. So if I start telling you that your dermatologist is wrong about your treatment for your psoriasis, don't listen to me, because that's really not my place. Or maybe I chose the wrong thing, your rosacea. But in any case, so that's the first thing. And nothing against the dermatologist, they mean well, and they're trying to help you, but it's really not their area of expertise. And like we just had talked about, there's a lot of misinformation out there about the safety of HRT. But that wasn't really your question, sorry.
Well, she asked
back off the rabbit trail.
Will your hormonal acne get worse on HRT?
Oh, yes.
Well, so typically when it comes to our treatments, so the regular HRT itself, you know, estrogen and progesterone alone, usually doesn't cause a lot of flare-ups of acne, but we also use DHEA as an adjunct to our HRT, and that does have the risk of causing acne in some patients. So that's something that some patients may experience more than others. We never really know who's going to be a victim of that compared to others. It's one of those things you never know until you try. But generally, it's a temporary phenomenon. It's not like while you're on the DHEA the entire time that you're going to be struggling with acne. It's usually as your body is getting acclimated to the medication, and then it passes and it gets better on its own. So that's something that, you know, once we get the doses stabilized, most patients do fine and don't continue to have an issue with acne. So.
I mean, and that's the other thing about hormonal acne. I mean, it's why you get acne as a juvenile. As you know, when you get these sudden changes in your hormones, that can trigger acne. And so when your ovaries are just starting to wake up, people get bad acne, and then that gets better as things stabilize. And as your ovaries start kind of going back to sleep, those rapid changes in hormones also can cause acne. So HRT can help that by helping to stabilize your hormone levels. So for a lot of people, if it's really hormonal acne, the HRT can actually help it.
Okay, we have another good question. Jackie would like to know, so she's on Winona for 6 months. She started bleeding yesterday and is having her first full-blown period in over 2 years and wants to know if that is normal. And if so, will it end like a regular period in 5 to 7 days? She knows everyone is different, but broadly wants to know what can she expect in the coming months or years?
Well, so typically as you start HRT, it's not uncommon to experience some bleeding or some spotting as your body is getting acclimated to the medication. It can also happen when we change dosages as well. So, you know, it's something that I don't usually get alarmed the first time it happens with the patient, but it usually resolves on its own. You know, it's your body responding to the medication because it is affecting the uterus slightly. And so it's something that, you know, we have to keep an eye on. If it doesn't resolve on its own, you know, within 2 to 3 months of you noticing this, then it's probably time to get an exam and get it checked out and make sure there's not something more serious going on. But sometimes we need to make adjustments in your medication. There are other things that we need to consider, but this is something that your doc will be able to work through with you, that you're not going to be alone in dealing with that.
Let me just say, not 2 to 3 months of constant bleeding, but
right. No.
Yeah, cycles for 2 to 3 months. Yeah.
Super common though, prior to having that year phase, right, leading up to and perimenopause, to have the inconsistent periods, but less common after the year mark ish.
The year mark is an arbitrary number, really, because we have to pick something to define menopause, and so arbitrarily that's been picked as 12 months without a period. Now we define it that way, but it's not like at 12 months and one day all of a sudden the ovaries just completely shut off. It's a really gradual process, and you know, to throw a rogue period out once in a blue moon is really not that unusual during the menopause transition. But if the bleeding is heavy or erratic or it continues, that could mean there could be an underlying problem that needs to be looked at.
Got it. Okay. Shannon says her progesterone lab results tend to go high when she takes HRT. Is this a problem?
You don't need to get lab results. That's the answer to that question. So really, labs are not very helpful to us in order to determine what dose you need or even to make adjustments. And so we really care more about how you feel. How do you feel in the medications? How are your symptoms responding? Checking labs and adjusting things based on that is not recommended. So we can use your symptom pattern better to help us to know how to treat you. So it's not a problem, but stop getting labs.
It's funny. I just got an email today from some head of some lab, home hormone test lab, saying, hey, you know, you should be doing a hormone test. You can make a lot of money with us, you know. And unfortunately, you know, that's become a problem in that the lab industry has become $1 billion industry, and they're really sort of pushing these labs on people. This was aimed at me as the CMO of a hormone company, but I get them just as a regular person. Quest is always sending me stuff. Hey, get this lab. Hey, get that lab. Hey, 20% off your lab. You know, it's like, well, I don't need those labs. So, you know, labs aren't always a good thing. And they sometimes, you know, and particularly with hormones, they're just not helpful. They're not accurate and they're not useful. So I would basically completely ignore what your hormones look like on these lab tests. The home tests in particular are, you know, these saliva and spot tests are particularly inaccurate, but even the blood tests aren't particularly helpful.
Yeah, somebody sent the other day the Clear Blue Easy menopause edition, and I was like, really? Isn't this like a pregnancy thing? Nope, everybody's on the menopause train now, so beware, people in the chat. Okay, Laura wants to know, she says she has a few questions. Her cycle stopped in February of this year, and 2 weeks into the medication, she started again with a vengeance. Her whole body has developed hives and bad acne. Is this normal?
Well, the hives, not so much. That sounds like a allergic response to something. I mean, bad acne we can see as your body's getting acclimated to medication, and also the irregular bleeding. We just mentioned that sometimes can be your body responding to the medication. So I think that, if you're one of our patients and you're plugged in with a doc, I would message them and talk to them about what you're experiencing so we can make changes if needed. Because it's important to make sure that you keep them up to date on your symptoms. Hives are not a normal response that we see to medication. So usually that's a negative response, and we would want to change your medication.
Okay. All right. We have Karen, who wants to know, or who shares that she felt best during her period and worse on days 7 through 17, and was very sensitive to estrogen, and has had a hysterectomy, and wants to know if she can benefit from HRT.
Well, we would need more information, but certainly if you're having symptoms, like menopausal symptoms, depending on how old you are, Karen, that if you're having symptoms that are congruent with menopause changes like hot flashes, vaginal dryness, brain fog, insomnia, I mean, the list of symptoms is over 100. I mean, we can't, possibly go through a comprehensive list here, but many women will find that they can benefit from HRT. Especially if they're suffering from symptoms. So if you're not sure, you can check out the website. You don't have to sign up to learn more. But if you wanted to go in and start the onboarding process, there's a symptom picker basically that has the most common symptoms that many women experience. And you could go through that to determine if you are experiencing those, to see if you might be a good candidate.
There's also a quiz on the website that you can take that can help as well. And the other thing is, the body doesn't like changing hormones. And so when you're cycling, your estrogens are going up and down, and your progesterone as well. And that can cause a lot of symptoms, which is what you experience. That's why you felt good sometimes in the month and not so good other. With HRT, the dose is kept the same all the time, so you don't get these big ups and downs. And so I wouldn't expect you to have the same response to estrogen and HRT as you did to the cycling estrogen that you experienced with your menstrual cycles. So the fact that you had that history before doesn't really anticipate that you're going to have problems with HRT if you end up being a good candidate for it.
All right, we have a question from Jen, who says she switched from the estrogen and progesterone cream to the estrogen patch, and she's been lowering doses for the past couple of months and has been spotting and having breakthrough bleeding, and wants to know how long this lasts when switching doses. Is it just 2 to 3 months?
I don't know if we can give you a time frame because every patient is unique in how they respond to medication changes. But I would say if you are making changes pretty consistently and regularly, like your body's having a hard time stabilizing. And so we might need to find the right dose for you and get you on that dose for a period of time before you'll notice the real benefits of it. So, if you've made changes a lot, like every few weeks you're doing something different, then we need to give your body some time to acclimate.
All right, we have T, who says, I'm perimenopausal at 49 and still have periods. Kumbaya on that. I'm 3 weeks into the program. Do I continue HRT during my period or remove the patch and stop progesterone during that time?
So you continue it the whole month. It's not like birth control where you have to take the placebo week to allow yourself to have a period. So HRT is more beneficial to get a constant steady state dose in your system for symptom regulation. So there's no benefit to taking breaks or to stopping for a week. In fact, you'll get a resurgence of symptoms. So just continue taking it every day, despite whether or not you're having your period or not.
Wardia is asking, after 10 weeks, I'm assuming this means on HRT, we should feel better. If not, do you change the dosage? Do you increase the dose? I guess is the question.
Well, it really depends on the patient. So, we really, at the 10-week mark is when we have a formal check-in, but you can message your physician at any time and talk to them about what you're experiencing and how your symptoms are responding. And so it's really a discussion that we have with you. Usually at that 10-week mark, we ask you, like, how do you feel on this dosage? Do you feel like you want to continue on this dosage? Are there any symptoms that are still bothering you? And it's a conversation that you'll have with your doctor about determining how to make changes if we need to make changes. It's not automatic. Not every patient needs to make an adjustment. Sometimes we get lucky, and the first time we go around with the dose, it tends to be the right dose, and patients are very happy. So, it's something that we have to discuss and come to a shared decision-making process with you on.
So let me say, almost 2/3 of the time, we hit it right. So
the algorithm works. Yeah,
I got to back up my algorithm. So yeah, that's the stats. But there's 1/3 of the patients where we need to do some adjusting.
Okay, so as I suspected, we have some comments also coming in on Facebook. So Facebook people,
we made it to Facebook.
We made it, but the funny thing
stuff.
is, we're gonna have to work it out because right now it's just showing me like I'm the person on, because I'm logged in via Facebook, and it's not. It should be showing all of us because you're the experts, obviously not me. So, but it's just showing me, and I think they can hear you, but they can only see me. So,
well, in my case, they're probably better off.
Patient with the process, we have a few kinks to work out, clearly. So, I mean, I guess it's good if you can all hear us and you hear the questions and the answers. That's good, and this will get better. Thank you for being patient if you're on Facebook and you're listening. I'm going to keep reading the questions here in the chat, but we do have about 2 or 3 over on Facebook that I'm going to try to loop into the conversation. Okay. Casa is asking if she had a bladder tumor in the past, but no other history of breast cancer in the family. Does that make her higher risk? She says she's sorry she has so many questions, but she's already a client with the medication, but never started because her doctor made her feel uncertain.
Well, so without further information, it's hard to say, but when you say the word tumor, what's most important is we need to know if that was something that was cancerous or not, because if you have a personal history of cancer, that does make you very high risk when you take hormone therapy. So that's something that you really have to discuss with your doctor. So if you're a Winona patient already, that's something that you really want to mention to them in that dialogue if it's not part of your onboarding medical history questionnaire already. Because in order to be safe and to take the best care of you that we need you to be completely transparent about your medical problems. Sometimes some patients are not right for getting this type of treatment through telemedicine. If you have a high-risk history, we had a condition that makes you at higher risk for taking a medication, then it might be better for you to have an in-person physician and be examined regularly. So telemedicine is not for everybody. But if you have a family history of breast cancer, taking the bladder thing out of the way, just having a family history of breast cancer does not disqualify you for being a candidate for HRT. So just because you had an aunt or a grandmother or a mother who had breast cancer doesn't mean that you can't take HRT. The only exception with that is if you've had genetic testing and you know that you have a genetic predisposition to breast cancer, that you're higher risk, then that might change things a little bit, and we would have that dialogue with you. But that's something that, sounds like you need to have a more in-depth conversation with your Winona physician.
All right. All right. I'm going to pivot over here to Facebook for 1 second, and we're going to just ask one of these questions so that everybody is getting a chance to have questions answered. All right. So Dawn here on Facebook says, are all estradiol patches approved by FDA considered bioidentical or only specific ones? Are there any generic estradiol patches considered bioidentical? Trying to check bioidentical patch options covered by insurance.
So when you talk about being bioidentical, basically that just means that the biochemical composition of the medication is identical to that which your body makes. So as female human beings, we have 3 different types of estrogen. We have estradiol, we have estriol, and we have estrone. So if the medication has one of those forms of estrogen, technically it is bioidentical. Now, there's a lot of different forms. Most patches out there that are given for HRT are estradiol patches. That's usually what we have on the market. There's many that are FDA approved that are out there. There's brand names, there's generics. lots of different options available. But as long as it's estradiol, which your body makes on its own, it is considered bioidentical.
The only patch I know of that has both estrogen and progesterone uses a synthetic progestin that's a non-bioidentical progesterone. But the estrogen-only patches, I'm not aware of any non-estradiol patches. I don't know that they exist.
Yeah, I'm not aware of any either. I think I've only seen estradiol.
Yeah, me too. So I think as far as if it's an estrogen-only patch, you're probably looking at a bioidentical patch.
All right. Let's see. We have one more question over here. Audra is saying she just placed her order, but has a question. She says she's in perimenopause and has a regular constant cycle. Will starting have any effect on her cycle?
If starting the HRT will have any effect on her cycle?
I think that's the
It
question.
sometimes throws off the first period or two. But for most women, once you get past that and you get that steady state, your periods return to whatever normal is for you. Sometimes they get a little bit lighter, which most people like. But for the most part, if you're having regular periods, after the first cycle or two, you should continue to have regular periods. And honestly, most people don't even have a problem in the first cycle or two. But for the most part, you can expect things in the long run to be the same as they are now. Maybe a little better.
Okay, good. All right. So live stream people, back to you. Just had a couple. Wanted to make sure that they weren't being ignored. And again, thank you everyone for being patient with the process. Okay. Kimberly wants to know how long, this is the crystal ball question of the hour, how long does it take for the estrogen progesterone cream to start working? Go.
That's not so much of a crystal ball because we have a lot of experience. Most people start seeing some relief within the first few weeks to a month, but it depends on the symptoms. So the hot flashes, night sweats, sleep disturbances, those are usually early winners. You don't get necessarily all the benefit, but you get some benefit early on for most people. Some of the other things, weight gain, increasing your muscle mass, hair and skin changes, those take longer. Those can take 3 months or even up to 6 months to really get the maximum benefit from those changes. So it really depends on which symptom you're experiencing, or for most people, it's a combination of symptoms. So most people get kind of an early win or two, and then kind of more prizes the longer you stay on it is kind of the way I think about it. So that's kind of what you can expect.
All right. Stacy would like to know, she says, can you start HRT while you're still getting a cycle? If so, how do you know how much of each one you need? And what each one meaning?
Estrogen and progesterone, I assume.
Okay.
Well, and the important thing with that is that when we really aim at your estrogen dose with our algorithm, and then we have to partner the progesterone with that in an adequate dose in order to protect your endometrium. So, you know, those two medications go hand in hand. So I usually think about the estrogen dose first, and then make sure that the progesterone that I'm prescribing is going to be adequate to protect that uterine lining from overgrowth.
Okay, Shannon would like to know, oh wait, it cuts off. Shannon, did she finish her? Shannon, I think your answer or your question, sorry, cut off. She was asking us something about Hashimoto's, hypothyroidism. Oh, is there anything I need to know about taking HRT while on thyroid medicine?
Really, HRT should not interfere with your thyroid medication, or it shouldn't change your dosage or anything like that. They really shouldn't interact. I do find that, like, if women are struggling with menopausal symptoms, sometimes it can be difficult to become euthyroid, or to get their thyroid under good control. So sometimes once we get their symptoms of menopause under better control, they'll tend to notice that they stabilize on their dosage of their thyroid medication thereafter. Although the drugs themselves don't interact with each other. It's more about your body getting in that place of a happy balance, and doing better overall when things are improved.
Thyroid medication is a really fickle medication. Doses don't tend to be stable, which is why you're probably having to get thyroid hormones checked periodically, because just for no particular reason, all of a sudden you have to increase or decrease your thyroid medicine. If that coincidentally happens to happen after you started HRT, people are going to point their finger at HRT, but the truth is it probably would have happened anyway. So you'll see online people saying, oh, well, I took HRT and then I had to adjust my thyroid dose. It's like, well, you probably would have had to adjust your thyroid dose anyway, because that's sort of the nature of thyroid replacement.
Lydia, let's get it together. Lydia is saying, being on HRT is beneficial for your heart. Under what circumstances would HRT not be good? For elevated cholesterol and high calcium scores. I'm personally a asymptomatic or heart disease, and I'm hearing conflicting information.
I personally don't know of a lot of literature out there on calcium scores. I know that they use that as a marker for your risk of heart disease, but I'm not aware of there being any negative information on calcium scores and whether or not you should be able to take HRT or not. I don't know if you've seen anything in that arena, Dr. Green.
Yeah, calcium scores it's sort of an emerging thing and somewhat controversial still. But really the bottom line is, if you don't have actual heart disease, even if your cholesterol's up and your calcium scores are up, HRT can be beneficial. First of all, hormone replacement therapy improves your overall lipid panel. It should increase your HDL, your good cholesterol, and decrease your LDL. Not like Lipitor will, like a cholesterol medicine, but you do get a kind of a small but helpful change in those numbers. Triglycerides can go up a bit with estrogen, but your overall, if you look at the overall cholesterol scores, they tend to improve with HRT. So I wouldn't worry about your cholesterol. As long as you don't have coronary artery disease, you don't already have blocked arteries, you haven't had a heart attack or something like that, then HRT is safe and should be beneficial. And HRT in the long run actually decreases your risk of heart disease, which is really one of the big important health benefits to HRT beyond just symptom control. So particularly somebody who doesn't have heart disease yet, but maybe has some risk factors, it may be actually even more important to start HRT.
Yeah, and I think it's important to add too that it's important to start it before the age of 60. I know we've talked about that on other webinars too, but 60 tends to be the magic number that if you start HRT after age 60, it can be more harmful. So we definitely want to get things started before that time.
Okay, Kimberly has a pretty basic question, which is, does HRT cause swelling? I'm not sure swelling.
So HRT can cause some bloating and some water retention. So in some patients that can equate to swelling. If you have a propensity toward elevated blood pressure, or you've had lower extremity swelling in the past, you might notice a little worsening of that as your body's getting used to the medication. But it's usually not something that's persistent. It's usually something temporary as your body's getting acclimated to the medication.
All right. Wardia has another question. She says she's menopausal about 2 years ago, took HRT for 4 months, then stopped because she got scared of using medication every day. She said she found us online and decided to try it again after 5 months. She's pausing. Is this okay?
So I take that as she paused for 5 months and then she realized she wanted to start back up again. And yes, that's okay. As long as you're before the age of 60, you're still having symptoms that are bothersome that you feel like need treatment, it's absolutely okay to restart HRT. Because what happens is you learn more, you get more knowledge about what's going on, you're going through your day-to-day and the symptoms are bothering you. And so there's no reason you should continue to suffer if we have treatment available out there. So I'm glad you found us online.
Yay. Stacy is asking, when you start, how long should you give it? I'm assuming that's HRT before dosage is increased or decreased? And also, if you still have a cycle, will the patch basically take over your estrogen, or will it bounce around since your estrogen currently bounces all over?
Well, we tend to want patients to stick with the initial dose. We do the 10-week check-in. We really I want to see a benefit for most patients. I want to know that they're at least feeling a little bit of improvement by the 6 to 8 week mark. So for most patients, by 10 weeks, we should really know, how they're feeling on the medication, and we can talk about dose adjustments if we need to at that point. As far as the estrogen bouncing around, so our female hormones are released in a pulsatile fashion throughout the month, especially when we're going through the normal pattern of hormone changes during the menstrual cycle. But when you're going through menopause, those normal patterns are not still continuing to, the hormones are not being released in the same fashion. So especially as you're making that transition, and actually the ovaries are winding down and not producing estrogen in the same amounts, you're not going to see that same roller coaster of hormones up and down. So it tends to be the patients that are on the earlier side of things, like still perimenopausal, that still see a lot more fluctuations in their body's own produced hormones. And so it's something that we can keep an eye on and we can discuss. Sorry, my house is getting really loud. I'm going to go on mute.
Okay, let me, there was a couple things I wanted to throw in there anyway. First of all, I'm
going to get off the camera because my husband just got home and it's time to show him that I bought him a dog for his birthday. So I'm going to bow out and then I'm going to come back on.
Have fun. Okay. Okay, so a couple of things, actually, just kind of a little trivia point. We call it the 10-week follow-up. It's actually 11 weeks. And what happened was when I designed this thing, I thought 10 weeks would be about right. And I found out after a while that actually that was like a week too early, because the idea is to kind of assess things about a week before that 3-month refill is going to go out so that we can change it before the refill goes out. And the 10-week was just too early because it was like, okay, we need to change something. And then, gosh, you got to wait 2 weeks before the refill date. And so we changed it to 11 weeks, but the 10-week nomenclature stayed. So everyone was calling it the 10-week follow-up, and I've never been able to get rid of that since then. So anyway, if you're doing the math, it's actually an 11-week follow-up, but at Winona, we all call it a 10-week follow-up, and that's the history of it. So that's not really so important. I just think it's kind of interesting. Couple of things. If it's a disaster, okay, if you're that person with hives, for instance, you don't want to wait 10 weeks. You need to get on that, okay? Or if you're having some really significant symptoms, or if you're absolutely miserable, we're not going to make you wait 10 weeks. However, if you can be patient and wait it out, you're less likely to have too much changing in the dose. You could end up on a higher dose than you really need if we change too quickly and too often. So that's why we try to hold off, but we don't want you miserable either. The other thing, hormone replacement therapy does not take over your estrogen, which is an important point because birth control pills do. Birth control pills work differently. Birth control pills basically overwhelm your body with a massive dose of hormones. Even the low dose birth control pills, this is how they're designed to work. And so the ovaries essentially shut down, and that's how they prevent pregnancy, because the ovaries basically like, oh, there's plenty of hormone around, I don't need to do anything, and they stop producing hormone, they stop producing eggs, and that's why you don't get pregnant. Hormone replacement therapy doesn't shut your ovaries down like that. It comes alongside your ovaries and adds back the hormones that your ovaries are no longer able to make because they're not as efficient as they once were. So it doesn't take over your estrogen like birth control pills do, which is really a benefit. But it does help get your estrogen levels more stable so that they're not bouncing around so much. And that's really one of the important ways that they benefit and they help relieve your symptoms. Okay, we probably beat that one to death.
No, but it was good. I could tell you wanted to say something and you were being polite. You were like, So let's see. The next question we have is from Tanya, this is an easy one, who wants to know, do we offer testosterone?
So the short answer is no. But if you've seen a few of these webinars, I never give a short answer. So The problem is testosterone is a controlled substance, and we can't do it with the type of telehealth that we do. So legally, we just can't do it. So it would kind of take an act of Congress, or at least a decision from the FDA, for us to be able to offer testosterone. Testosterone is important for women, and so we offer instead DHEA. DHEA is a hormone. It's mostly a prohormone, but it gets broken down almost immediately within 30 minutes of taking it into estrogen and testosterone. It gives a teeny amount of estrogen. It's really the testosterone that's the benefit. The nice thing about DHEA and the doses that we provide is it's not going to push your testosterone outside of normal female levels. So you're not going to get the bad testosterone side effects you can get with other things. Testosterone is important, but unfortunately people go overboard with this, particularly with the pellets and the shots. And they can really, easily overdose you with testosterone and give you some really significant side effects, which, some of them are irreversible. And we get a lot of patients at Winona that have tried the pellets, the testosterone pellets, and had a really bad experience. And they switch over to us and we get them on one of our treatments, and they do much, much better. So if you can do testosterone right, it's actually a good thing to do, but the problem is most people that offer testosterone overdo it. And one of the reasons is testosterone can give you this sort of euphoric feeling when you first get it. So like the first pellet or two, women love because, oh my God, I feel so good. And then as it starts building up, that second, third, fourth pellet, the side effects really start kicking in, and it kind of becomes, it can become a big nightmare for people. So I'm not a fan of the pellets, as you can tell, or even the testosterone shots. There are some testosterone creams when dosed appropriately that can be helpful, but unfortunately we can't prescribe that just because of the way testosterone is classified by the FDA. So easy question, long answer, sorry, as is my way.
It's okay. More information is better. That's what I say. More is more, Dr. Green. More is more. I know some people argue with that theory, but that's my take.
Yeah, people tell me, yeah, you gotta stop talking so much.
If I had $1 for every time somebody said that to me. So we have another question that you can shed some light on. Mordia wants to know, is the patch better than cream?
So no, and I would say that the cream isn't better than the patch. They both work great for most people, and so it really comes down to personal preference. Some people like the idea of only having to use something a couple times a week. So with the patch, you put the patch on your skin, you leave it there, you change it twice a week, and some people like that convenience. Other people find it annoying to have to wear a patch all the time, and so they'd rather just put a little cream on once a day and be done with it. They both work great. The couple things that are different is the patch is estrogen only, whereas the cream, we can put estrogen and progesterone in the same cream. So if you use the patch and you have a uterus, you're going to be taking a progesterone pill at the same time. So you're still going to have to take a pill every day, and then you just change the patch twice a week. With the cream, we can put the estrogen and progesterone in the same cream, so you're only having to use one thing for your estrogen and progesterone needs. So that's an advantage of the cream. The other thing is that occasionally people have a reaction to the adhesive in the patch because the patch has to stick to your skin. So there's like an adhesive, like a Band-Aid kind of thing. And over time, some people can get a reaction and a sensitivity to the adhesive. So sometimes you see the patch giving a rash, whereas the cream doesn't. But they both work great. They're both, I think, really good choices for people. The other thing is the patch is a lot more expensive. So I'm a cheapskate, for my own, I like Kirkland. Like if I can buy it at Costco, like why buy name brand when I can get the Kirkland, whatever. So that's me. If something works just as well and it's a lot less money, like why would I spend the extra money? So if you come to my house, I'll serve you, what's considered nice wine. But my wife and I, when no one's looking, we drink the cheap stuff because we like it just as much. So anyway, that's the way I am.
That's good. If it works, don't fix it.
That's right.
All right. Sherry has a question for us. She says she's 56, still gets her period every few months, and it comes with severe depression. She started on progesterone and is waiting for her period to see if progesterone helps with the mood issues. She trialed the DHEA and got horrible headaches, so she stopped taking it and wants to know, is that okay? And if you recommend that she retries and pushes through the headache, that the DHEA was really bad, and she says she never gets headaches.
So if you had side effects from the DHEA, I would try to live without it, because why get headaches if you don't need it? And you may do fine without the DHEA. Progesterone alone is unlikely to solve all the issues. I think we talked about this earlier, that I would really encourage you to think about adding estrogen to that. Or maybe some of our patients call the cream a progesterone cream, even though it's estrogen and progesterone, so maybe you are getting estrogen. But I have found that for a lot of people, hormone replacement therapy can help those symptoms of the menses around the period. So usually that's happening because of a sudden change of hormone, depending on where exactly in the cycle, but usually it's that big crash of hormones that happens right when the period starts, and that can cause depression and other things. Hormone replacement therapy, since you take it every day, it blunts that change. And so you don't get that huge hormone crash, and that can help symptoms like depression that happen around the period, and other symptoms that women experience with their period. So I think it has a really good chance of helping you. Again, if it's just progesterone, may help some. I think the estrogen would be important. Look on the bottle, if it says biased, you are getting estrogen as well. That's the estrogen part. And so that's good. And if the DHEA is making you miserable, don't take it. It's not worth it, in my opinion.
Okay. Laura has a question that I was going to respond to here. She was saying she's
Wait, hang on, time out 1 second. How do you like the dog?
The dog was a hit. He was very surprised.
Wait, you didn't tell us what kind of dog.
He's like a terrier mix. I got him. We adopted him from a rescue, so we don't know exactly.
Yay! I love it. That's cute.
Okay, sorry to interrupt.
It's okay. No, it's good. Happy birthday to your husband. All right. Laura is saying that she doesn't know how to get a hold of her Winona doctor, and that she's emailed with no response. Laura, can you tell us in the chat where you've been emailing? That might help us be able to help you. Typically, you should be able to reach out to your doctor in the patient portal. If you don't know where that is, let me know, and I can drop a link in the chat as to how to find your patient portal. But I'm not sure if you're just messaging customer service or how you're going about reaching out, but let me know in the chat and we'll try to help you. Okay, let's see who else here. Lisa wants to know, do your refills fill automatically?
So typically by default, we usually put patients on auto refill unless they specify otherwise, because that way you won't have a chance of running out of medication and you can continue your therapy seamlessly without having a break unnecessarily. So it works for a lot of patients and it works well.
I'm going to bounce over here to the Facebook folks for a second because there's a few more questions. So hang tight, Facebook people. Somebody over here is asking, let me get the names correct. Shara is saying, is HRT okay for those with cancer, not hormonal cancer?
For most cancers, yeah.
Not a great idea.
There's a few cancers where it's probably okay for. Thyroid cancer is one of them. So that one is usually okay. Most cancers, though, even if it's not going to cause a recurrence of the cancer, if you were to get a recurrence, it can put you in what's called a hypercoagulable state, which means you're more risk of blood clots, and the hormone replacement therapy can exacerbate that, can make it worse. So cancer is usually not okay. There are some, certain skin cancers would be okay as well. So you really want to talk to your Winona doctor specifically about the cancer. Occasionally, there are certain cancers where it's like, yeah, but the oncologist says, no, HRT is fine. That could be another story as well. So it's something that, the most cases, the answer is going to be no, but you definitely want to have a conversation with your Winona doctor about.
That's good. Okay, one more over here from the Facebook crew. Kay is asking, let's see, she's asking about constant bloating. She says she was dealing with it and it has subsided quite a bit in just the first week of taking 200 milligrams of progesterone and 2 milligrams of estradiol. Yet she notices that many relate initial bloating as they adjust to the hormone supplementation. Is estradiol or progesterone anti-inflammatory? She's saying she's seeing such a difference so soon.
I don't know necessarily anti-inflammatory, but I think that, you know, if you noticed a lot of bloating beforehand and that you're feeling better with the HRT, it's having a positive effect on your body. So, I mean, I think that's a good thing. It sounds like things are going well.
So no offense to our Facebook friends, but I like to tell patients that most people do really well, and the ones that don't make posts on Facebook. So just because you see, if you're doing great and there's a bunch of people on Facebook that have the opposite thing, it's like, well, you don't. So that's, I mean, I feel bad for them, but for you personally, that's a good thing. So don't be worried. You know, everyone's experience is different. And as we talked about before, you know, this is a really individualized approach. And so I had somebody get all mad because somebody on Facebook was on a different medication than them. It's like, well, yeah, they probably had different symptoms. Like that's the whole idea of personalization. So, you know, it's great to have this group of women that are going through the similar thing that can help each other. And I think it's a wonderful thing. On the other hand, you know, be careful about the transference of like, well, somebody else is having this problem, but I'm not. It's like, oh my gosh, am I going to develop this problem? It's like, probably not. So don't be, it's bad to have anxiety about things that haven't happened because they probably won't. And so there's no point letting the potential of a problem kind of ruin your good experience.
Yeah, I would agree with that. Okay, the previous person who was asking us about cancer, she's saying that she has, hold on, and now I've lost it. She was telling me what type of cancer she had. Well, shoot. Guess I'll just have to circle back to that. We do have another question from someone named Kay. She wants to know, how do you stop the tingling and burning sensations? I don't know if that's like a menopause symptom or if that's a result of taking HRT. Kay, if you're still here.
Tingling and burning of the hands, of the vaginal tissue.
Right.
Can you say more about that, Kay, if you're still on the Facebook session, and let us know in the comments, and we will come back to Facebook. Okay. Karen over here on live stream is asking, what is the difference between bioidentical and synthetic hormones, and what are the bioidentical hormones made from? Plants like yams. And that's a question, not a statement. I read that.
The answer is yes. Go ahead.
Make it sound like a question. Plants like yams.
Well, so I mean, we talked about it a little bit earlier, but basically being bioidentical means that the medication itself is biologically, and the chemical compound of the medication is identical to what your body's producing. So that can be in a compounded medication. It can be in a medication you get from your pharmacy. As long as it's the same type of hormones that your body is producing, they're considered to be bioidentical. Synthetic hormones, however, are medications that are not identical to what your body is producing. So typically, most of the time we think of synthetic hormones like birth control pills, and birth control hormones are the most common ones that you see out there. You'll see words like ethanol, estradiol. You'll see progestins instead of progesterone. So basically, by using bioidentical, you know, we're using medications that are the same as what your body would produce naturally. So your body tends to tolerate them better and have less side effects and less resistance to the medication. And you do better with, you know, it tends to help your symptoms better. So ours are plant derived. So, you know, we at one point we're using yams, but sometimes there's a yam shortage. And so we use other things as well, but we can say plant derived, right, Dr. Green?
That's right. Yeah. And generally a yam-like vegetable would be, I think, the right way to.
A root vegetable of some sort.
Right. Yeah. By the way, there's this marketing term out there you want to be cautious of, and that's biosimilar. So the people that make synthetic hormones want to try and compete, so they call their hormones biosimilar. But that's really very different than bioidentical.
I have a cat
Nope.
here trying to participate. That's Rover. It's like time for him to eat. Now he's going to let all of us know. Pushy animals. Okay. Casa says, thanks for answering her questions. We're getting a lot of thank yous. Okay. Catherine says she started 3 weeks ago and is already feeling benefits. She wonders about DHEA and PCOS. She's opted not to take it right now.
Well, so for some patients who have a history of PCOS, which stands for polycystic ovarian syndrome, their body has an inherent issue with having the correct balance of hormones, and so they tend to get a mismatch of hormones. Like their ovaries and their uterus aren't talking and communicating very well. So typically we see irregular cycles with that. We can see an excess of male hormones in a woman's body. That's my daughter with one of the kittens creeping into the camera. Okay.
Oh.
And so if you're still suffering from a lot of PCOS-like symptoms, even as you get into perimenopause, sometimes we want to hold off on the DHEA at that point in time because it could exacerbate those symptoms. However, if you're no longer suffering from the symptoms of PCOS, like you're not dealing with what we call hirsutism or excess hair growth, like male pattern hair growth, or you're not dealing with acne regularly, if those symptoms tend to subside, because our hormonal environment will change and evolve as we go through perimenopause. And a lot of times the this imbalance of hormones that you have with PCOS is no longer an issue as you get into your 40s. So if it's no longer an issue for you, you're not suffering with those symptoms on a regular basis, you could still take and be a candidate for the DHEA, but you need to have a conversation with your doctor to talk about the risks and benefits before you make a decision on that.
Okay. Very good advice. All right, moving on. Hi, Dawn. Dawn from Winona. Hello.
Hi, Dawn.
Hi, Dawn.
She's been very quiet, Dawn. I'm surprised you didn't have a question for us. Okay.
Yeah, me earlier today.
Did she? Let's see. Dawn. Yeah, I know. Okay. Yeah. Catherine is saying she's 56 in menopause. PCOS symptoms are balancing. Okay. That's good. I think.
And that's pretty typical, honestly. I think it's fairly rare to see people with like raging PCOS in their 50s. It seems to be more of a 20s and 30s, maybe into the 40s kind of thing. And it tends to get better.
Okay. The other question that we have is when we were talking earlier about how do you stop tingling and burning sensations? The response was the feeling is like a neuropathy. Hands and feet are tingling and the hot flashes. She's asking, how do you stop that?
Well, so those can actually be caused from a variety of different reasons. And so if you have not had that evaluated by a physician, you might want to do that. They can be symptoms of menopause. In fact, some women will start to notice like they feel a sense that their skin is crawling, like itchiness of the skin, dryness of the skin, and sometimes a sense that like, you know, tingling, pins and needles, but there's also some more serious medical conditions that can also cause those symptoms. So it's important not to just chalk it up to menopause and make sure you get an appropriate workup to rule out some of the worst things. So I would get evaluated for that formally with an in-person exam if you haven't already.
All right. I think we have made it to the end of our questions, everybody. Unless there's anyone else who has anything. Oh, wait, Dawn, did she ask us a question? Oh, she did. Hey, Dawn, thanks for coming in with a final question. Team Winona. Okay, Dawn is going to ask either of you for the lightning round. Is it beneficial to add DHEA if you're taking low-dose testosterone?
If you're already taking low-dose testosterone, then I would stick with that. I don't think you'd get any added benefit from doing the DHEA. So we use the DHEA in order to give patients a bump in their testosterone because we can't prescribe testosterone through our platform via telemedicine because it's considered a controlled substance. So in that sense, if you're already on testosterone from another source, I wouldn't add DHEA on top of that.
Totally agree. It's amazing. We see patients come in from other places on these crazy, I shouldn't say crazy, on these these regimens that just don't make sense. And I see a lot of people that are testosterone and DHEA and other stuff. It's like, what are they trying to accomplish? So if you're using testosterone, you really don't need the DHEA.
All right. Any final questions? Going once, going twice. Wow, I'm amazed. It doesn't happen often that we make it through the questions like this early on. All right, Facebook folks, anybody, final questions? Just going once, going twice. I'm just making sure. I think we've got everybody here.
We don't have to do Final Jeopardy. What do you know?
Right? Gonna have to start to have some bonus lightning round questions. Okay, well, I think if we've answered everybody's questions, unless Stacy has a question.
She's typing.
That was safe to go and it's your husband's birthday.
That's funny. And Facebook people, hopefully next time we'll figure out how we can show all of our faces, not just mine. So sorry. I mean, God only knows what face I'm making when it's just me on the screen. So hopefully it's not just me with some like frozen Max Headroom situation over there. And thank you for getting that reference, Kat.
That's a blast from the past.
Yeah, it is.
Okay. Stacy says her doctor prescribed testosterone, progesterone, and a thyroid medication and told her that at 45 she doesn't need estrogen. Dun, dun,
I respectfully disagree.
I agree. I disagree too.
So there's this theory out there which makes no sense to me, and the pellet people push this, and that is that if you give a woman enough testosterone, their body is going to convert it into estrogen, which is technically true, but it's kind of a screwy way to give estrogen to somebody. It's like, well, why don't you just give them the estrogen they need? So, and that is where people get the testosterone side effects, because people are trying to push the biochemistry by overwhelming the body with testosterone to make estrogen, which just seems totally backwards to me. I assume that's where they're coming from, but I think that most people that do a lot of menopause management would just absolutely disagree with that statement.
All right, I'm just checking over here.
Oh, and she just typed that she's having side effects from the testosterone. Not surprising.
Yeah. Well, yeah, and that's it's kind of a weird way of doing it, and I'm not sure. Well, I kind of know why this got so popular. Well, particularly the pellets. The pellets, the best reason for pellets is that it makes a lot of money for the obstetrician, which is kind of a horrible thing to say, but unfortunately it's sort of true. Again, you can tell my pellet bent, but testosterone is important for women, but women don't need massive doses of testosterone. It's neither do men, for that matter. In moderation. I mean, unless you're a competitive bodybuilder and that's what you're going for, then more power to you. But otherwise, it's really not the right way to do it.
All right. Okay, friends. I think we've made it through. Oh, Stacy says her level was 150. I don't know.
Free or total? That would be a really high level if it was free.
Stacy, care to clarify?
That's okay. It doesn't matter.
It was the max. Okay. Shoot. Well, friends, thank you for joining us. It has been a very exciting session, and come back next month and ask all your questions again. Tell your friends if they have questions. Come see us. We'll answer them and more. The more part's the fun part. We like to tell you stories. Dr. Kat always has a story or something to share. Dr. Green, we know you do too. So come back here for the humor, the fun, the laughs, the info, the knowledge, all the things. And if you live in Central California, you can come see Dr. Green and myself at a very exciting Bakersfield event. For those of you who want to do some mat Pilates and learn more about Winona in person, come visit us. There'll be some information on our social channels and within the women's group coming up here this month. There's more to come with Dr. Kat in person too, so just stay tuned for all the things. And Dr. Kat, we should also put in the chat that you should follow Dr. Kat on her Instagram.
Oh yeah.
Give your Instagram plug.
Yeah, so trying to share more information, more educational videos, and so my handle on Instagram is Dr. Kat OBGYN. So you'll see more content coming from there. So if you want to have some down to earth, real talk, and real information, there's no pretension and there's no negative talk about anybody else. We're just trying to share information and give you more knowledge. So
yeah, definitely check her out, and you'll see lots of fun things. You can learn some fun facts about Dr. Kat, and I see that you're posting a lot more now, so yay for you.
I have help now.
Yeah, I see you have a team of helpers, and good that you do. So yeah, stay tuned, everyone. And we'll bring you more exciting facts, fun, educational things, community events, and all the fun that's part of menopause.
Yes. Well, have a good night, everyone. Thanks for coming on.
Yeah, thanks for coming.
And Kat, enjoy your new pets. You have several.
We went from 2 very small caged pets to now 5 with animals running around. It's a menagerie now, so it's going to be interesting the next few days.
You're turning into me, Kat. I got pets galore over here too, so okay. I like it. All right, we'll see you guys. See you soon, and thanks everybody for joining.
Thanks, you guys. Bye.
Bye.